Okay, it's 7:05. We're going to go ahead and get started. So I hope you can hear me well. I understand that we have Christine Dawson on, who is unmuted. She's self-muted. Mary Daniels, who I can't unmute. Melody, I can't unmute. And Pooh, I can't unmute. And then Teresa Stone. So good morning, all. And I see I got a type in from Christine, and I got a type in from Teresa. So you guys are here, and I'm glad to have you here. Brought to you by Smart Dog Productions. This is WFLHCA for West Florida. And so we'd like to present some interesting topic we talked about before, and that's the police risk of heart disease. We're reopening this topic because I've been invited to speak to several police organizations and would like to have a better idea of what the relationship is of medicine with the police. When I was an intern and a resident at Tampa General, there was a very close relationship between the house staff and our police officers, where our conjunction was in the emergency room, involved together in the Knife and Gun Club that would meet usually Friday night, certainly Saturday night, and on the weekend. And we'd be involved in trauma, gunshot wounds, knife wounds, drug activities, and the aftermath. It would come into the emergency room, and we'd try to put them back together. And so we worked very closely with this group of police officers to protect us in the emergency room and to protect them. And so we developed a working relationship that was very tight. As a matter of fact, when I was an intern, was on like 36 hours straight and was driving home on Kennedy Boulevard, stopped at a stoplight. That was enough for me to fall asleep momentarily and bump the bumper, the rear bumper of the car in front of me. And so accident, and car stopped, and everybody got out, and we waited for the police. The police show up, and basically there were two officers, a young guy and looked like a very senior officer. And here I was in my scrubs and lab coat and half asleep. And so it was obvious what I did, and so I did say, I fell asleep at the wheel at the stoplight while I was waiting. And so the police officer, young guy, said, let's give him a ticket, blah, 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 cited some citations. But the old guy took him over the other side of the parking lot and said, we need to talk for a minute. And you could see him talking over there, and then he came back and said, we're sorry this happened, but there's not going to be any citation on this accident, and file with your insurance companies. And so what turned out to be not a good thing turned out to be a pretty good thing. And I talked to the police officers afterwards, and he said, we work together and in the emergency room, and he said to the young officer, this guy may save your life someday. You don't want to piss him off. So that was very nice, and I've had a great relationship with the city police department since then, working with fire rescue, EMS, pre-hospital care, and all those things. But as time goes on, you drift away, and you're not in the emergency room at the point of care, and your only relationship is in your neighborhood, where you have your neighborhood patrol and the security of your own house and family and friends and neighbors. And so I thought I would talk a little bit about what I see as an abandonment of the relationship that we had in terms of the care of the police. And so let's talk a little bit about that, and certainly in cardiology. And so the police risk of heart attacks is 70 times that of other people during the job. That's pretty significant. 15 years less lifespan than average American, not dealing with police-related trauma, but dealing with life events involving disease. 50% chance of a heart attack 5 years post-retirement. Average age when suffering a heart attack, 49. Wow, that's a rollback, because the average age now seems to be 61, about 25 years ago was 54, and so it looks like for some reason the police aren't getting the level of care that we're giving everyone else if the average age is 49, because we've done so much. The acute cardiac events, which are called MACE, M-A-C-E, Major Adverse Cardiac Event, are right now standing at about 3% per year of people with known cardiac disease. That used to be 9% per year. There's ways of reducing that to 1.5% per year. So the police must not be getting that. So the average cost of an in-service heart attack is between $400,000 and $700,000. And so somehow this seems to tell us that there's some neglect in the advances in medicine within police department. So let's look and see what that is and why, because I really would like to know why. And so what are the risks for heart disease in police department? Well, stress would be the number one. And we see that with SOCOM, our military, special operations warriors. We see it, air traffic controllers, anyone who's involved in severe stress. We see it in shift work. Sedentary 90% of the time and then suddenly ramp up. We see it fire department. Same shift work, ramping up from 0 to 60 a matter of 10 or 15 seconds. The diet on the street, the diet in a patrol car is not the best in the world. Sleep deprivation is common. Working several jobs, you're on 24, off 48. And so many people work several jobs in fire department, probably in the police department as well. Let's talk about what the legal protection is that the state legislature has given to police officers because, one, they're public workers, public service workers, and two, they have an increased incidence of heart disease. And so there's been some protection afforded them by the legislature. And let's look at that and see what that means and why. And so it's called the Heart and Lung Law, sort of colloquially. But for me, what is covered is heart disease, hypertension, and tuberculosis. And perhaps being a cardiologist, I haven't seen a case of TB for 20 years. I certainly am in the emergency room. I'm on the wards. No TB in my hospital. Maybe somewhere else. At Tampa General, when I was an intern, I had one case of TB. So the heart and lung law may not be a heart and lung law, because if TB is one of the exceptions that have been given extra coverage with police officers, then that is probably an anachronism. And maybe it was a rare communicable disease. Maybe it was a common when we had tuberculosis centers. Now that's not the number one on my list for communicable disease. And so I think that's an anachronism. So let's call it the heart and hypertension law, since that's basically the two disease states that are more common out of those three, and the other being relatively very uncommon. So it's 112.18. I think there are 40 states that have a law enforcement, firefighter, or correctional officer special provision relative to disability. So I think there's 40 states, and this is the Florida statute. So let's go to the Florida statute and see what it says. And 112.18 says firefighters and law enforcement or correctional officers special provision relative disability caused by tuberculosis. We're going to skip that. Heart disease or hypertension resulting in total or partial disability, etc. And so with that in mind, the policeman must have successfully passed a physical examination upon entering any service to make sure that he doesn't have those diseases pre-existing. And then he's covered under this law that says the burden of proof is upon the state to prove that it wasn't acquired on the job because of the job stress and the commonness of heart disease on the job. So let's move on and see what we can figure out from that. And so how do we now recognize and treat heart disease, hypertension disease in law enforcement? Well, I've looked on what's being offered multiple cities by agencies that have been created to deal with, I guess, occupational hazards. And it looks like those companies in Florida, many Florida cities, other states, seem to be offering this kind of testing: whole body ultrasound, multi-system blood testing, insensitive, non-specific, low-yield stress test. Hey, that's not what we're doing. And so why is that what the police are getting? So let's look at this again a little bit, drill a little deeper and see what we can find out about that. So here's an offering that I found online for police officers in municipalities. And so echocardiogram, hey, that's good. I like that. But heart function, aorta, aortic valve. I'm not sure why they specifically have mentioned the aorta and the aortic valve. What about the mitral valve? So that doesn't really make a lot of sense. And then there's no strain echo. And if you're keeping up with echocardiography, you've got to realize that strain echo is now becoming a big player. It took 4 years for our team, including our echo tech, to really get a grasp on what strain echo meant in terms of taking care of patients. So strain echo started out with me with cardio-oncology and ladies who have breast cancer getting what may be potentially cardiotoxic chemotherapy. Now it's gone on to hypertensive heart disease, being able to recognize those at highest risk of having a cardiac event with hypertensive heart disease. Wait a minute, wouldn't that be this group? And then thirdly, recent reports, mitral regurgitation, that this is a predictor of problems in the immediate future with significant mitral regurgitation. And so I'm not sure why strain echo hasn't been incorporated in it, and why echocardiography, according to this, is focusing on the aorta and aortic valve. Let's move on. Well, the carotids, carotid artery ultrasound. Well, I really don't need that, because for most people that's not a good screening test. All I need is to see one carotid. I need to see if there's any carotid atherosclerosis, any atherosclerosis of large vessels that are easily obtainable and viewable would be the carotid arteries, because they're right on the surface. And so what I want to know is, does the patient have atherosclerosis? We're not specifically looking at carotid vascular disease because that's not a good screening test. What we're specifically looking for is a marker for coronary disease, and that is atherosclerosis of the carotid. Now, atherosclerosis of femoral arteries are a little more sensitive than that of the carotid. 35% on the carotid correlation with coronary artery disease, 37% on the femoral arteries, but I'm willing to give up 2% in order to be able to find an accessible artery that's easily viewed, that we can get some information off of, and so that's the carotid. Very superficial, easy to do. But so I don't need that whole study. All I need is CIMT to see if, just to look and see. And then we've got, wait a minute, now we're talking about the heart and lung law. Why in the world are we looking at the liver, pancreas, gallbladder, kidneys, spleen? I can't remember looking at a spleen ultrasound unless specifically focused on someone who has chronic lymphocytic leukemia. Ovaries, uterus, testicular, prostate, bladder, and thyroid. Well, that seems to be casting the net very wide, and it seems to be casting in the wrong place for the wrong fish. Because if we're talking about heart and hypertension, we're certainly barking up the wrong tree. So let's move on and see what other tests are being offered are police. And so we got cardiac exercise stress test with EKG. Well, we know that that is a very low sensitive and specific test. In other words, it's not very sensitive for picking up heart disease, and unless it's in the most extreme, and I don't think you'd be a police officer if you were in the most extreme heart disease, because you wouldn't be able to work on the street. And it's also not very specific, because there's lots of things that stress test can be limited to in terms of exertion limitations for lots of reasons, such as anemia, chronic lung disease, and so forth. So this is not a sensitive or specific test for heart disease, and it's certainly not good for early heart disease if you're interested in prevention. So I would replace this with cardiac CT. And now we can throw in CT myocardial perfusion imaging, because that's our latest information with technology as we've developed. We have 3 ways of doing CT MPI, myocardial perfusion imaging, without much trouble at all on a regular CT scan. We'll talk about that later. We've been talking about that for the last 2 meetings. And then electrocardiogram, well, that's a poor, down and dirty screening test that really doesn't tell anything for most people. There are a lot of false positive heart attacks, especially inferior wall MI, poor R rate progression, and so forth. So we know it's not a very sensitive test. Might be specific, but not very sensitive. And then a pulmonary function test, well, maybe for fire department guys who are going into smoke, but they don't have a lot of fires anymore, and they're not getting a lot of smoke exposure, and they have lung devices that they wear for protection with oxygen. So I'm not sure what that's all about either, unless it's cigarette smoking, and that seems to be going away in most professional cultures. And then how about blood pressure? Well, there was no mention of blood pressure, but what's important to me is not the immediate blood pressure today on this encounter when I'm seeing you. That doesn't seem to be very important at all. It seems what's really important is what is your blood pressure over a 24-hour period. And so we all know white coat syndrome, and someone who comes into out of traffic, and they rush to get here to a doctor's office, and then they rush into the exam room, and then they're getting a blood pressure by a nurse. And so those blood pressures are high. You certainly can do better if you put somebody in a quiet room and let them sit in there for 5 minutes and have an automatic blood pressure taken 3 times and averaged. But that's kind of hard to do in a busy doctor's office. Not very many people have 24-hour blood pressure recordings or recorders available for doing that in the office. I'm not sure why, because they're convenient, accessible, and affordable. And I don't know how you can practice internal medicine management of hypertension without this information. Let's go and see what other tests are being done and take a quick look at that. And so we've got multi-municipality current evaluations, the heart and lung law, but I'll call it the heart and hypertension law because I don't see TB. We've got a comprehensive metabolic panel. Well, that's a broad screen and probably unnecessary and not targeting. We got a complete blood count. Not sure I would want that. Certainly a lipid panel with cholesterol and glucose. That sounds good. Thyroid panel, well, not unless somebody has tachycardia or symptoms of hyperthyroidism or hypothyroidism. Hemoglobin A1C, well, if you have an elevated glucose, we might do that. Urinalysis, we'll probably have that in your primary care doctor. Occult blood study, low yield unless you're symptomatic. PSA, I don't want to go there because we all know that that test has resulted in overuse of procedures and overdiagnosing a disease that for the most part is benign, chronic, and smoldering in certain age groups. Men testosterone levels, not sure about that. And then ovarian cancer markers, CA-125, not the usual screening test. So I'm not sure why these are being done in people that we're targeting for the heart and hypertension. So let's move on and see, well, what would I do if I was focusing on the heart and hypertension law? Well, I would get an echocardiogram with strain because strain is probably the best predictor in an echocardiogram of those people who have hypertension, who are going to have cardiac events in the near future. And so that's a good heart function test, and that's a good predictor. So it took us 4 years to adapt to strain, and we had the best teachers and we had the best equipment, but that's just such a new technology that has got new literature and that has new normals, and it takes a while to be able to incorporate that in a cardiac echo practice. So CIMT, that's a surrogate for coronary artery disease, and so that's particularly useful to look at the carotid for medial thickness, for hypertension, and carotid plaque. Coronary CTA with coronary blood flow, which is CT-MPI, which I've shown you that we've been able to develop and do 4 different ways. And so, hey, that's a home run for me for screening, especially if you have low radiation, which we have. 24-hour blood pressure recording in hypertension, invaluable. Don't leave home without it. Lipid profile with glucose, risk for coronary artery disease, no question, extremely valuable. And of course, a good history in regards to family history, symptoms, physical examination has a low yield, and so forth. So we have also, has been a development of doing coronary CT, and I found in a couple counties that's being offered, but it's being offered as optional self-pay. And so I'm not sure why it's not offered as standard of care. And then it's offered for people in this county and another county. That's an inconvenience. And then it's offered using a suboptimal, not even suboptimal, a failure to meet the minimal equipment requirements, standard of care. Failure to meet standard of care, 16 slice scanner. Wow, that's discarded equipment. Why would you use that on our police force? That doesn't make sense. And then unexperienced operators and non-diagnostic studies. Well, what do you mean by that? Well, can you tell me more? And I would like to tell you more. And let's take a look. And so here's 2 scans, same patient. And this is scan number 1. And as you see, you can't see a lot. There is a coronary artery. It's in the distribution of the left anterior descending. There's some pieces of calcium. And then there's another piece of calcium in the diagonal. And then these other things are just everything's kind of grainy and blurry. So it looks like, must have been a large person, must have been low KV, must have been, it doesn't look like the heart rate was going fast because I don't see much misregistration. This study would be called a non-diagnostic study. And then comparing it to a study later, same patient. It's not that patient was not evaluatable. It looks like that you could get a good study on this patient. And it looks like I can see the coronary artery very nicely now. I do see an area of misregistration along here, and that has to do with artifact from breathing or motion or heart rate. And but the arteries are pretty well defined, and I can go inside and see things, and it's good differentiation. And so the only difference between these 2 studies, there's probably more difference. One difference is basically resolution. This is poor resolution, 16 slice scanner, 64 slice scanner. Standard of care, standard of entrance into this business is 64 slice scanning, and this is inadequate. There are other inadequacies here. It's probably too much radiation, and this is probably much lower radiation because of using step and shoot and iDose and iterative reconstruction, getting it down to about 3 millisieverts, and this would probably be 12 or 15 millisieverts. And so there you go. And you can see, let's look at the aorta. You can't even see the 3 aortic cusp. Very poor definition. I can't even make out the left atrial appendage. So much for that. This is what we're offering our police officers, probably on a discounted basis. So let's go, and then who's in charge of this? Well, there's a weight loss doctor who's in charge of this particular program that I'm looking at. And so why would we not have cardiology guided screening, since the two diseases that we're looking for are heart disease and hypertension? Query. So let's talk about how could we better manage heart hypertension in law enforcement officers. Well, what I propose to do, if I was king of Tampa, Hillsborough County, or multi-county area, or Florida, and here's what I would do: cardiac CT. Cardiac CT has been mandated in the state of Texas, for anybody offering health insurance on adults. So that's not a giant leap. Cardiac MRI, well, that's not readily available, but it certainly can tell us if somebody has a scar in their heart. It can tell us the ejection fraction, and so that's not routinely needed, but it's a good backup, especially if you're at advanced cardiac imaging. Cardiac PET is extremely useful for obese people, and they're not that obese, firemen or policemen, but it's something to be used and reckoned with because of the recognition of hibernating myocardium and scar tissue. Strain and 3D echo. Well, the 3D echo helps us get a better strain picture. And so if you're into strain, you'll see the 3D probe is able to give us the parameters we need to measure the best strain. Why is strain useful? Again, cardio-oncology, ladies with breast cancer getting cardiotoxic, potentially cardiotoxic drugs. And why else is it helpful? Well, it's helpful in hypertension because it can find those patients who are high risk in hypertension. And how else is it helpful? Well, I see mitral valve disease now. So we're seeing lots of things that are stepping up on a daily basis with strain to show us that strain has reached the mainstream and it's ready for regular cardiology on a daily basis. So how do we get there? Well, we started in 2006 and we said, let's add cardiac CT. Let's take the CT 64 slice scanner we have. Let's put step and shoot on for radiation reduction. Let's add iDose later for iterative reconstruction. And now we have model-based iterative reconstruction. Let's set up a fellow training program for USF. Let's get also funding and fellows from Largo and from Northside. And let's do this properly. Let's get a fourth-year fellow to train. And let's look at new equipment so that we can see patients in the emergency room and do them within the hospital instead of the diagnostic center. And so that's coming up this year or early next year. Let's look at the PET scanner. Let's upgrade the PET scanner so that we can actually do cardiac work on the PET scanner. Let's activate a gate. Let's get a cart. Let's do post-processing. Let's get isotope in, and let's activate the computer. So a lot of money spent on that. And it's used for viability, whole body imaging. I refer others to Houston because they have a $100 million commitment to their development of PET CT software. We'll get a new isotope called fluoropuridaz, and then it won't be so expensive. 2011, upgrade CMR, 36 channels, add on a computer, $60,000, purchase a coil later, $30,000, add a gate, $30,000. And so some of this is being added this year, where we're going to do T1 Molly, and we're going to add the navigator for breath hold. And so it looks like we're going a long way in continuing to develop this. So it's not something that happens overnight. It's you can see a 10-year process, of recognizing cardiac imaging is here to stay. Advanced cardiac imaging is better than what we did before. And so let's keep track of this and let's upgrade. And so these are the upgrades that resulted in this center with lower radiation exposure for PET, 3.5 millisieverts or less, with coronary CT, low radiation exposure, again about 3 millisieverts around there, lower for something we call a placogram, cardiovascular MRI, bread and butter daily work in many patients with many problems. And now with coronary CT, recent upgrade in terms of cognitive science where we can do myocardial perfusion imaging and calculate FFR, not just by sending out to California to HeartFlow for $1,500, but actually doing in-house stuff, looking at the myocardial mass, looking at the lesion that subtends that mass, whether the lesion is 75%, the cross-sectional area, or what the diameter is, and look at the length of the lesion. We have calculations, tables, information that I can quantify FFR in, probably about a minute. I can do those calculations and come up with that information, which is now anatomy plus blood flow in one study. And more later as we start adapting that technology to our routine daily workflow. We'll talk more about that, but it's extremely important. Here we are in Tampa. Here's our core laboratory, and here's 2 fellows that we're training and 1 student. We have people coming and going all the time here. We have Dr. Tariq is coming back in today. We have a new fellow from Largo who is Nick Koch, and then we have our 4th-year fellow, Dr. Michael. And so we have a very active training program. And this is our clinic. This is our acquisition center. We're looking for not only stenosis, which the whole world is looking for, that's where the money is, but we're also looking for liquid plaques, plaques that are little blebs, like a little pimple inside a vessel, a blister that has a high risk of rupturing that can cause instant, sudden death or acute MI. Not 2 good choices. And so this is a target, and if this becomes target specific, because 75% of heart attacks are caused by this, totally changes your focus from looking for stuff to fix to looking for stuff to prevent. And so we have advanced cardiac imaging training, of which there are COCATs 4 new guidelines that basically penetrate all training activities of cardiac fellows, 1st year, 2nd year, and 3rd year, with a knowledge of PET, CT, MRI, 3D echo, and strain echo, meant to permeate all activities that you're doing, whether you're in the EP lab, structural heart disease, coronary artery disease, you're on a non-invasive service, you're interventional, whatever you're doing, this needs to permeate your activities. A 4th year non-accredited year of training to be a specialist, 40 training programs in the United States, training 40 imagers a year. Most are at universities. Most people stay at the universities after they're trained. Some stay in private practice. Our last, I guess, 1, 2, 3, 4, 2 and half of them in private practice and half of them with the university. So 50-50 with our program. Most training programs provide only 2 imaging modalities. This was a survey that was done, and there are only 2 programs that offer all modalities for the 4th year training program, and that is Brigham and Women's Hospital and HCA Memorial Hospital. HCA is the only freestanding radiology center that's a cardiac center that it was converted to. It's the only center that has 2 advanced cardiac imaging private practitioners, and we're the only 2 in the country that are in private practice for advanced cardiac imaging. What important truths do you know that everyone else does not know? And I asked Mary Daniels this recently, and I'm going to share with you as a close circle some of mine, just a few, but enough for you to chart a clear path. And so this raises big questions. 15% of all Medicare patients have had an exercise SPECT scan. This test is worthless for evaluating patients with chest pain. Blue Cross Blue Shield did a study, 40% false positive, 65% false negative in 47 centers in Michigan. Diagnostic cath is no longer needed, and we can prove that on a day-by-day basis here. Coronary bypass graft is not being used much. Stents are down 30%. Took 17 years to get 60% of physicians to give an aspirin for a heart attack. Note the attrition rate for physicians is 6% per year times 17, so we simply replace the doctors instead of training them. The insurance companies have locked in the standard of care by not authorizing payment for PET, CT, and MRI. Basically, they make each $250 million to say no to these procedures. It costs $7,000 to the medical system if a cardiologist touches you. It takes 3 days to evaluate a patient with chest pain who's hospitalized. 50% of chest pain patients leave the ER without a diagnosis, and 5% with chest pain are sent home, come back to the ER with acute coronary syndromes. Obviously, if we're segueing into a value-based system, this is not going to get us there. And so there's a mandate from CMS that we're either going to be bundled or valued in some way. And that means that the reimbursement by 2018, not very far away, 2 years away, is going to be 80% based on value. 80% of reimbursement is going to be value. Fee-for-service will be gone in 2020. I don't know how we're going to get there. You can see how we've gotten to EMR and how staccato it was to get there. Let's see what happens to this. But I think we ought to be prepared, and we ought to be moving in that direction, which means we can't be practicing legacy cardiology. Here's a new dramatic change. This is basically a change in testing based on results. Well, let's look at this. This is the Scott Hart study, the continuation of the study. The continuation of the study is basically projecting out and looking at patients. It's not what the study was designed for, but it was continued for a mean of 20 months. And what it showed was this little red line here is mortality on patients who got standard of care testing. Standard of care testing and whatever treatment that followed, whether it was angioplasty, bypass surgery, or medical treatment. This was standard of care testing, which is stress echo, stress test, nuclear stress test, etc. This is the mortality from that. Now, for a control group, that's the control group, and therefore you have to do the same thing in the intervention group. So the intervention group was standard of care testing as well, plus CT scans, And over a period of 20 months, the difference is a 50% decrease in rate of fatal and non-fatal heart attacks. Wow. Well, it's not exactly a controlled randomized study. It is a controlled study. It's a continuation study, which has its downside. But it looks like with CT scanning, we are better able to target which patients need angioplasty, which patients need bypass surgery, who needs to be on a statin drug, and how to take care of these people. And so we're able to structure that and put each person in a pigeonhole and play this out with each one in their bucket, and we know how to take care of each bucket. So, well, our success has been pretty good to the point where we've dropped major adverse cardiac events from 9% per year to 3% per year. And now, by implementing this, we drop it to 1.5% per year. This is good because we're having less heart attacks. It's bad because all of our research is based on major adverse cardiac events. If we don't have any, then we have to extend the research. If we were counting on 9% per year and now it's 3% per year, it looks like we've got to either extend the study by 3 times what it was planned, say 3 years would be 9 years, or we extend make a larger population. Instead of 100,000 people, we need 300,000 people. And so that's pretty incredible. And we'll have to come up with a new marker, which I have some suggestions for. But let's go on. This has explained to many people, and Mary was included in that, this explains what the concept is. What is the concept? What are we talking about in heart disease? What's happening inside the plaque? And there's a danger zone, there's a safety zone, and so you'll be interested in this. And so here's the interaction of genes, the lipid pool, inflammation, macrophages, that may be considered the same thing, microbiota, and I refer you to Stanley Hazen, Cleveland Clinic, who's going to be here May the 12th at noon to be talking about the effect of microbiota and coronary artery disease and Tamayo. And so the arterial wall damage necrotic core forms inside, which is that liquid plaque that we've color-coded red on our CT scans, evolves to fibrofatty, which is red and green, and sometimes sort of yellow or pale yellow, and then fibrotic, which is blue. This is red and blue, and this is fibrotic, which is blue, and then calcified, which is the deep yellow, and then it might go on to be atherosclerotic stenotic, which is a small percentage of those, or it might just stay there and it's one and done, and then you add calcium to it, because a calcium nidus will be an accretion zone for further hydroxyapatite deposition. So this is danger zone. Here's a 4-day plaque. That means in 4 days it ruptured. Here's one that took 188 days to rupture. Here's one that took 420 days to rupture, all having one thing very much in common, and that's necrotic core. Probably also positive remodeling. And so those are hallmarks. And so then going over here, and the convergent divergent double cone seems to be something occurring. And I have 21 other factors. Coming over here, this is a calcified artery that was surveyed 10 years later and found to have more calcification, but no stenosis. And so that's the calcium accretion that we talk about. And so the low value system, whether this is office SPECT scan, it's very expensive, office stress echo, stress test, whatever it is, it's a low value, and it's a terrible gatekeeper. And we singled out the SPECT scan, but you can look at stress echo, you can look at stress testing, you'll come up with the same numbers. 40% false positive, 65% false negative. A terrible gatekeeper, and it's why when a cardiologist touches you and sells you the six-pack of history, physical, EKG, echo, SPECT scan, and cardiac cath, that it costs $7,000 to have a cardiology encounter on the average in terms of the medical system cost. And hospitalization, well, 3 days to get through this system, and 60% negative cardiac caths. The new value added by advanced cardiac imaging, which is going to be value added, high value for the new value system, is a CT scan, which we have an outpatient cost of $329 total cost, including having a creatinine, a radiology overread, and a cardiology read, and probably review with your cardiologist at the site on a follow-up visit. And so MRI, not too expensive compared with the other stuff. New gatekeeper, bypass this triage system. That's the old system that's using 50-year-old technology. And so how's that play out in the emergency room? Well, this is supposed to be troponin. This is echocardiogram. Patient low intermediate risk can be evaluated and triaged in 90 to 120 minutes and care decision made and going home with a diagnosis, or at least knowing what's not wrong with you, hopefully not something bad. And so history of a patient, and here's a former New York policeman who moves to a local city in Florida, passes a routine physical exam, and joins the police department. Well, wait a minute, does he have heart disease? Well, I don't know. What kind of testing did he have? Well, probably might have had EKG, maybe an echo, and very low discriminators for future plaque rupture are to find out if you have a plaque. So, and what happened in 2015 is he woke up from sleep with jaw, chest, left arm, elbow pain, went to the emergency room, was evaluated, had some negative tests, which would be EKGs and cardiac markers, usually not an echocardiogram, and was sent home. And so perhaps these tests weren't sensitive enough and will get more sensitive in the future. Perhaps he was having GERD or reflux, or maybe he's got cardiac problems. Well, nevertheless, his cholesterol is elevated, was get on a statin drug, resulted in liver enzyme elevation, so that didn't work. Later had a SPECT scan, minimal supple reversible defect or artifact. Again, 40% false positive, 65% false negative. What a test. Later, echocardiogram, but no strain, which is the predictive part of echocardiography. Medications, none. Well, it was a fail. It was a fail on statin, and so he's on no medication, not even aspirin. Well, as I said, it took 17 years to recognize the value of aspirin. And so he decides he wants to get a coronary CT, and that's offered to him as part of the program, optional, self-pay. And so he goes to the center he's directed to, which basically does not meet the minimal standards, has this test, and is diagnosed as having some coronary disease and perhaps a 50% LED. And I don't know how anybody could read this, but this is the information that was read. No mention that there's a lot of coronary calcification all over the place, which is a high risk factor for coronary disease, and this should certainly be included in the diagnosis. Lipids, well, he's got some good lipids, got a low HDL. He's got the usual coronary artery disease profile that we see all the time. What to do next? And here's our lipids again. I made another copy of the same slide, so we just skipped that. And here we go. Well, this is the coronary CT that was done with adequate equipment, with low radiation, and you see the detail, and you can compare it to the one before, and able to see that he has a total blockage of the left anterior descending, total blockage. So that's a lot different from back here, you know, when he was told that he had a 50% LAD lesion, which I don't know how you can read that, it's non-diagnostic, and now he's got big-time disease with a total blocked artery. Well, this explains everything. This is probably what happened when he went to the emergency room in March 2015. He probably occluded that artery at that time, and the tests were not sensitive enough to pick up on it, and he has collateral flow coming backwards. Well, what about his strain? Well, he's got abnormal strain. Well, that's a predictor that there's a problem, and there is. What about myocardial blood flow? Well, we did measure that because we can measure FFR now on everybody just on my computer within a minute or two. And so we measured it, and it turns out it's decreased. Where? Right here, right at the equilibrium point, where blood's coming in this way and meets the total occlusion, blood's coming retrograde meets the total occlusion, and so that's the area in the sort of the anterior lateral area, apical, that there's decreased blood flow. And so abnormal FFR, abnormal MPI from CT, and abnormal strain from echo, all zeroing in on this is a problem that he had, that was that event that resulted in him being off from work at that time and then back to work. Undiagnosed heart disease, which is so common. And I'm not sure why we're dealing with undiagnosed heart disease in police officers, since they have a high risk. And here's his totally occluded artery. You can see this is an artifact from either breathing, movement, or heart rate. But this is the real McCoy, and you can see here's the contrast, here's the calcium, here's the occlusion, calcium not even in the interpretation from the previous center, and then here's the blood flow coming probably retrograde and filling this way and then filling this way and stopping, and this is total occlusion. And so let's look, total occlusion. This is an artifact called a phase artifact. And so in order to interpret myocardial perfusion imaging, like any perfusion imaging, whether it's SPECT scanning, PET scanning, or MRI, you've got to be able to recognize artifacts. And so this is an artifact that I can show you on the CT scan that's called a phase artifact. This is the real McCoy. This is the distribution of this left anterior descending diagonal perfusion, and it's apical, anterior wall, superior apical. And so now I'm taking the coronary arteries, which are here, and I turn the heart so the apex is right here, and I'm taking this polar map that shows apex, anterior, lateral, septal, inferior, posterior. I marked the phase-determined boundary artifact that I read from the CT scan, and then I marked the anterior wall damage from the left anterior descending occlusion. This is either damage or significantly decreased blood flow. What it really is lack of iodine. There's no iodine. There's less iodine there compared with there, subendocardially compared to endocardial, subendocardial, and epicardial, and averaging and then comparing this in a ratio and then color coding it. So much less iodine in this area during this study, which was called a rest study, but really it's a post-nitroglycerin, post-contrast, post-beta blocker study, because that's what this patient had. In the future, I'm going to be showing you post-ivabradine, post-regadenoson, so-called rest studies, because we're going to use regadenoson for coronary vasodilatation instead of nitroglycerin, and we're going to use ivabradine, which is Corlinar, instead of a beta blocker to slow down the heart rate. And ivabradine is a funny channel blocker. Medical treatment: PCSK9 instead of a statin, an exercise program, diet, mostly vegetables and fruits, check pulse test and Tamayo levels. This is inflammatory markers. This is markers of gut bacteria metabolism. And then he's going to attend our lecture by Dr. Stanley Hazen, You Are What Your Gut Bacteria Eat, May 12th, 12 noon. And I want to invite you as well to Memorial Hospital Auditorium for this program. Where do we go from here? What are we doing? How do we better promote our imaging? And so the HoloLens, can that help us understand coronary disease better? Can that help my fellows and my students learn more about the heart? Perhaps. We're going to do a demo project here. How about working with other companies? Well, we've worked with HeartFlow, and they make available this kind of FFR imaging. We work with Vital Images, which makes available this kind of color coding of plaque composition. We work with Vital Images, and we've done MPI now. We look at convergent, divergent, double cones, and Navier-Stokes equations. We're interested in storing all of our data and post-processing with AI and storing every little thing in bins so that we can project and predict future outcomes based on past morphology, functionality, and blood flow with AI. And so these are the things that we're exploring as part of our future, and this is what we're going to be training our fellows in, and we want our nurses to be up to date and understand this as well. So this is time to call it quits. Thank you so much for attending, and I hope to see you next week, and we'll talk more about how our technology is rapidly changing and how it's helping us understand many groups in terms of their evaluation and treatment. Not only those people with some risk factors and family history of heart disease, but also those people who protect us in our neighborhood by protection services, that is the police, who unfortunately have the stress to give them a high risk for heart disease and are getting the wrong application of old technology, and hopefully we can segue them into new technology and a better culture and advances to preventing heart disease and early recognition. Thank you so much, and I'll see you next week. Bye-bye.